ADHD has become a prevalent disease in the United States. I'm sure almost everyone can think of a friend or classmate who has been diagnosed. Today, I'm specifically going to be focusing on the prevalence of ADHD in white children. Some topics I will touch upon are ultimately, within this population, who is most affected, how does this affect their schooling, some national trends with this disease, pros and cons of medicating children with ADHD, and some demographic comparisons of children of different minority groups. Diagnosing children with ADHD can be especially difficult because many of the signs and symptoms are normal for children who are developing. Guidelines in the American Psychiatric Association's Diagnostic and Statistical Manual, the 5th edition, are used to diagnose ADHD. In order for children under age 16 to be diagnosed, at least 6 of the symptoms listed in the book must be currently present and have lasted for at least 6 months. There are 3 categories of symptoms, which include inattention, hyperactivity, and impulsivity. Some of these symptoms include making careless mistakes, trouble listening when spoken to directly, fidgets when seating, talking excessively, and trouble waiting one's turn. Another key element in diagnosing children is that they demonstrate functional impairment at both home and school, not just one of these places. The reason I chose to investigate the population of white children who have been diagnosed with ADHD is because they're diagnosed more frequently than some of the minority populations. Most of the disparities that occur begin in kindergarten and last until 8th grade. Originally, this was raising the question as to why more white children have ADHD than minority group children. However, studies have come to show that these minority populations are underserved and simply are just not being diagnosed, even though the signs and symptoms are present. Statistics show that the odds of ADHD diagnosis for African Americans, Hispanics, and children of other races were 69% lower than white children, which is very significant. Within the population of white children who have ADHD, it is important to note that boys are more affected than girls. This most likely is not a genetic difference, rather than it is the fact that signs and symptoms show differently in boys than in girls. In boys, symptoms are more externalized, such as the urge to run around or high impulsivity. In girls, symptoms may appear as inattentiveness or low self-esteem. In children, it is arguable that the effects of ADHD are most seen in the classroom. It is more difficult for children with ADHD to listen and stay focused, sit still, complete their work on time, and follow instructions. For this reason, children with ADHD need special treatment in school settings in order to perform to the best of their ability. The Individuals with Disabilities Education Act and Section 504 of the Rehabilitation Act of 1973 outline 2 federal plans that can cover children with ADHD. These are an IEP or 504 plan. Some accommodations that may benefit children with ADHD are extra time on tests or assignments, the use of technology, environmental changes limiting distractions. It is crucial for a team of specialists at the school to work with teachers, parents, and the student in order to create a personalized plan that will benefit the individual. Overall, the number of ADHD diagnoses have been increasing over time. I would like to now discuss what the possible causes of ADHD are and if these causes can be linked to an increase in diagnoses. The biggest risk factors are having a parent with ADHD, having some of the more rare candidate gene variants, which can include the dopamine D4 receptor, dopamine D5 receptor, and serotonin 1B receptor, having prenatal lead exposure, and prenatal smoking exposure or premature birth. When connecting this to the increase in diagnoses in white children, it is said the factor that most profoundly causes an increase in ADHD is maternal smoking rates. One of the most widely used solutions for ADHD is medicating children. There are definitely pros and cons of doing this, however. The pros include better ability to focus for longer periods of time, increase in motivation, and an improved school performance. There are also social improvements. However, there are some significant negative side effects as well that can be potentially harmful for children. These include a loss of appetite, sleep problems, which is typically insomnia, an upset stomach, GI problems, and irritability and mood swings. As you can see here in this chart, there is a large variety in medications for ADHD. Costs vary per month depending on which brand you get and the strength of the pill. Without insurance, Adderall, which is the most well-known ADHD medication, can cost around $140 per month, or up to $750 for 100 pills. Some other common brands and their costs are Ritalin, which is cheaper, approximately averaging $78 per month. With insurance, following a diagnosis by a doctor, these drugs are much more affordable. There are some additional ways children can benefit from various non-pharmaceutical treatments. This can include dietary changes such as implementing more polyunsaturated fatty acids. Also, simply getting more exercise and outdoor time can decrease ADHD symptoms. It is important for a regular sleep schedule and parent intervention when necessary to keep their child on track with schoolwork. To conclude, I have 2 questions for you to think about. The first, if you know someone with ADHD, are they medicated? If yes, what are some of the effects of medication you've seen, both positive and negative? If no, what do you think are the biggest pros and cons of medicating? The second question is, how as a society should we work towards fixing the gap in diagnoses between white and minority populations? Thanks for watching.